Welcome to the Surgery and Therapy Summit interview with Dr. Aviva Wolff. Aviva, thank you so much for giving us your time today so that we can learn a little bit more about you.
Thank you, Robyn. It's an honor and a privilege. So thank you for inviting me. And I'm super excited about this novel new platform and just so fun to be a part of it.
Thank you. Yes, it is. It's a new concept. It's a new idea, new ways of learning. So let's hope that it is all successful. But Aviva, I've been following you for a while, and I have to say that I'm completely blown away and in awe of all that you have achieved and how much you managed to do in a day. Could you tell us a little bit more about where you began and your career journey to where you are today?
Sure. So I started like most of the therapy listeners and participants here as an occupational therapist first, and then a couple of years later, I already knew early on that I had a passion for hand therapy. So a couple of years in, I began specializing in hand therapy and then sat for the exam and was a certified hand therapist and clinician for many years, mostly at the Hospital for Special Surgery in New York. But always I'm blessed and maybe also cursed with a very inquisitive brain. So I bore very easily, and I'm always looking for answers and for explanations and for a deep understanding of everything that we do. So that kind of led me to explore some of the mechanisms, some of the outcomes of our interventions, our approaches. And I was extremely fortunate to work with in an institution, in an academic institution with extremely highly regarded surgeons who were top in their field and like at the cutting edge of technology. So that introduced me to new approaches, which led to the development of certain rehab approaches. And really, it was a very step-by-step kind of approach. In 2006, we first published our approach to rehab for elbow instability, which has since become like the standard and norm, but that's something that we started in the late 90s and tested. Our very first was in 2000. I was fortunate to work with Dr. Bob Hotchkiss on that. And then I worked with Scott Wolff on a lot of his wrist biomechanics research, which led to some of our development in scapholunate ligament instability and dart throwers motion approaches. And that work really made me realize how little I know about the research process and how much more I have to learn. So that's when I made the decision to go back to school and get a doctoral degree. That was at Columbia in motor learning. And my doctoral research ended up being in grasp control in children with cerebral palsy. I'd already been doing work in the motion lab, so it was a good place for me to do my research. And then at the time, I was running the hand therapy department, but it was way too much. So I had to step down from that, started in the motion lab. And that's really where I kind of took off and started putting my energy into developing clinical testing approaches to the upper extremity for complex upper extremity conditions like brachial plexus, like cerebral palsy, and ultimately where my focus is now on musician injury. So I had the access to the lab and the knowledge and the clinical experience, and it all just kind of came together. It was this just like perfect confluence of things. And now I'm just at this pinnacle of enjoying what I do so much because I'm pulling on all these different skills, the clinical, the research, the science, the teaching. So it's just been so like boatloads of fun. That's all I can say.
It's so nice. Your face just lights up when you speak about your career. And isn't that a gift in itself, that we do what we love? And I do believe everybody finds their niche, and everybody is led down a path to ultimately work with the patients they need to work with in the environment that they need to work in. And it certainly sounds like you were gifted with that. So it's a beautiful story.
Yeah. And I just want to say, I mean, not to make it too Pollyanna-ish, that, like everyone else, I've been, up and down the career existential path. Is this right for me? Do I need a shift? So each time I made a slight shift, it was because I was either feeling a little like plateaued, or a little, I don't want to use the word bored, but maybe just not getting the same excitement and stimulation out of the work that I was doing. But also, as an OT, at the end, what really, really drives me is helping other people on some level. So whether it's one-on-one in the clinic, which still gives me the most satisfaction out of everything I do, or helping on a more global level by developing approaches that can then be shared with other clinicians and kind of pushed out on a much broader scope. So you're helping more people and more patients.
That's called impact factor. And I absolutely resonate with you. I'm very similar to you. I have a very low boredom threshold. And so I'm always loving to create and learn and dive deep and research and participate. But it's being able to help many people on a big scale, which also drives me, because by impacting one therapist, that therapist is going to then impact hundreds and thousands. And
then when you publish something, I'm sorry for interrupting. And then, so when you impact one therapist, you impact all the patients that therapist treats. When you publish something, you impact all the therapists who read, or all the clinicians who read your work and then implement that. So it's even, the scale continues. So that's really the impetus for sharing the knowledge that we believe in, or we know that works.
I'm glad you mentioned that, because that was going to be my next question for you. Because I remember when I first got into publishing, it was because I was working with an associate professor, and his first question to me was, "Are you interested in writing journal articles?" And because I just started working there, I said yes, just to impress him. And then little did I know, he was very, very serious about it. And we started writing papers together and started looking at our patient load, looking at what the literature said, where the gaps were, and how we could contribute. And his best analogy to me was that writing a paper is like taking a block of ice with a chisel and a hammer. When you first start, it's overwhelming. You can't see the beauty. You don't know the process or the journey. But as you chisel away at it and spend more and more time with your sculpture, eventually the beauty emerges. And that is exactly how I experienced writing papers. I absolutely loved immersing myself in that literature, research, and writing process.
That analogy that you just used is a phenomenal analogy, because I read somewhere recently the difference between art and sculpture, and perhaps between an artist and a sculptor. And a lot of people approach writing as a blank canvas. Like, what do you see on your paper? A blank canvas for you to put the work out onto. And it's actually exactly the opposite.
Mm-hmm.
It's a sculpture that's just waiting to be revealed. So it's there. You just have to peel away the layers and and reveal it. So I love that you use that analogy, and I think that could be helpful for a lot of people who feel that, oh my goodness, where do I start? It's a helpful way to conceptualize it.
And the place to start is just pen to paper, and to dedicate that time to that writing process. And because it is three-dimensional, you know what you want to write about. So you don't have a blank canvas, because you know exactly what the literature world needs. And it's such an important part of our therapy. I know for myself, as you know, I've specialized in a technique with only level 5 evidence. Judy called it casting motion to mobilize stiffness technique. And so a lot of my publications are on my case series reports, but they have helped so much when I've tried to explain to other therapists about its application in dupotrons. Oh, please read my paper. It's so easy to then do that, because when you've written that paper, you've already gone through the entire academic process of organizing your thoughts in a great way. Plus, you've gone through the peer review process. So you know that when they read that, that's better than just looking at social media examples. I think there can be a fine line between what we're seeing people do on social media and what is actually been researched, published, and peer reviewed, and has kind of gone through that whole process to publication.
Absolutely.
And I think what's also so important is that we do publish so that people can easily reference our work, especially the new ideas that are coming out. There's so many people with great ideas, but if we don't publish, how can people apply it and reference it? So it's really nice. And we were talking a lot about, in other conversations, about starting a writing club. So I just want to ask you, because that's, again, you being able to work on a grander scale, because now you're bringing people together, you're giving some guidance, then they go off and do their homework.
Yeah, so I actually run a research writing group with the PT Ortho Fellows at our hospital, and it's a once a month group that meets. And you mentioned case series or case studies, and that's a perfect place to start for beginning writers. Even though many journals now don't like to take case study papers, I would still encourage anyone who wants to start writing to begin with a case study or a case series, because a case study is a mini research paper. The process that you follow when you do a full-blown research study is the same as a case study. It's just with more people. So it's a really good place to learn research properly and then to structure the writing. And actually, last week, I gave a talk to our clinical review panel, which is composed of occupational therapists, actually anyone in the rehab department who's interested in writing. And we went through a very systematic approach to how to begin writing a paper, and just some tips and tricks and hacks. So it's daunting, but like anything, like making your first splint, like making your first dynamic splint, like treating your first flexor tendon patient, like treating your first unstable elbow patient. It's very daunting at first, but once you've done one, you feel a little more confident. Once you've done 2, 3, right, then it becomes just natural. So like anything, it's a skill. Anyone can learn it. And I agree with you 100%. I think that the onus is so on us to get our information out there, to share with others. And publishing is one very powerful way.
Absolutely. Yeah. And, it's much more easily to do, because if you look at these randomized control trials, they're expensive, and you almost have to be affiliated with an academic institution. You need to be able to get the consent and to get the ethics approval. And like for me in private practice, I wouldn't be able to do that, but I could certainly take what I'm seeing every day and publish those case series so that other people can think, oh yeah, that's a great idea. Let me try that.
Yeah. And it's certainly much more difficult in private practice, but it is also possible to conduct a research study. You just have to know how to go about it. In the United States, there's a national IRB institutional review board. So that's like an ethics consent that is available to private practitioners. Again, you have to be familiar with the process, and research requires mentorship. And all researchers have mentors. It's kind of a little bit on the apprenticeship model. You require mentorship pretty much throughout your entire career. So anyone who is embarking on research on their own should have a mentor who can walk them through the process and check in and make sure that they're following proper guidelines.
And also you can do a PhD through publication, can you not? So if you do a series of publications after an MSc, I think you can submit for a PhD.
I don't know about that. I know that part of a PhD is publishing your work, and in lieu of a dissertation, you can publish a series of publications related to your work, but it has to be part of a pretty regulated and mentored and institutional process.
Yeah, it's got to be robust, absolutely.
Yeah.
And then tell me a little bit about how you are working. I watched your link that was in the media with your musicians lab, which is really incredible. And what I enjoyed about watching that is the precision in terms of the assessment process, because you are absolutely able to see exactly the position of the joints and the muscles and how everything was moving to come together, and analyze that in order to be really specific in your treatment plans.
Yeah. So as I mentioned earlier, having access to a motion lab and the work that I've done in movement analysis and motor control and biomechanics really gave me an advantage when I began working with musicians, in terms of trying to understand exactly what they're doing during their playing. Musicians, they move so quickly and they play so quickly. So it's hard to pick up on everything just by watching them, even though our eyes are amazing tools for observation. And definitely it's a good place to start. But when I started noticing a lot of overuse, what happened to me was I kind of fell into the musician work, and I was sought out by Julliard to cover a few hours a week there to treat their injured musicians. And over time, I noticed these patterns developing, like which musicians were being injured, which instrumentalists. And I realized we have this all backwards. We really need to be preventing these injuries. Let's see what they're doing with their instruments. So I'd have every single musician, no matter what, haul their instrument into the clinic, take out my cell phone, walk around them, take 360-degree videos, stills of their posture, playing slow, playing fast. And then we'd play it back and pause and look at the individual joints and positions. And I didn't have to say anything. Most of the musicians would look at it and say, that's what I'm doing with my thumb? That's what I'm doing with my wrist? That's so wrong. And then I'd have them go back, discuss it with their teacher. I'd make recommendations. And then I started refining it. So for certain instruments, for certain conditions, Sometimes I need more than one camera to really hone in on what's going on. So I'll use like a 3-camera view. Sometimes we really need to slow it down. But for the most part, for the clinician who is seeing a musician in your clinic, a cell phone, 360-degree views, if you know what you're looking for, will give you the information. And again, like I said earlier, it's practice. The first time I looked at a musician, I didn't know what I was looking for. Now a bassoonist walks in, I pretty much know exactly what to hone in on. Obviously, you listen to their symptoms, you do a full musculoskeletal exam, but watching them with the instrument and analyzing that joint by joint, segment by segment is invaluable.
It's incredible. And that brings us to the workshops that you're going to be doing for us at the summit. So the first is that assessment process. Do you want to tell us a little bit more about that workshop?
Yeah, so in the first workshop, we are going to do exactly that. We're going to go step by step on how to assess a musician, whether it be a professional musician, a recreational musician, an amateur musician, a child who's learning an instrument for the first time. And what we'll do is we'll approach it as my approach is we have to approach musicians differently than our standard patient, because these are people who have very specific occupational demands. So just as we have approaches to how to treat the athlete, we need specific approaches to how to treat the musician. So the assessment includes a musician medical history, specific assessments that are developed specific to the musician, and then the musculoskeletal exam that again is tailored to the musician, and then most importantly, the playing assessment, how to conduct the playing assessment. And we will watch a video, we'll break it down. I give a little outline to a checklist, so to speak, to as you're observing different postures, to check off whether they're there or not. So it just gives a picture of what's going on, and then how to interpret those findings. So it's interactive in the sense that you will get to watch musicians' videos in real time and then assess them on your own. We'll do an assessment together, and then you get to assess them on their own.
Oh, that's so nice. That's invaluable information, because even if you don't treat musicians, or you're not in an institution where there'll be those musicians referred to you, there are many patients that you will get in your caseload ad hoc that will be musicians. They might be amateurs, they might be professionals, and it's just so nice to feel a little bit more confident when you begin that assessment. So, and then the last thing is moving on to the treatment. So you're going to do another workshop on how we can.
So the second workshop is customizing the treatment to the instrument and instrumentalist. So every instrument has its own demands, physical and biomechanical demands, and demands on the musculoskeletal system. And then musicians' bodies are all different. So the instrument is standard, but our people's bodies, anthropometrics, as we call it, are different. So you might have a musician with a longer neck playing violin and a musician with a shorter neck, a pianist with long fingers and a pianist with short fingers. So how do they accommodate without injuring themselves to play repertoire that might be more appropriate for one body type versus the other? Take a tuba, which is huge instrument, and a 4'10" player, which there are, and how do they play that instrument without injuring themselves? So we'll look at all that. One thing that I found that was missing for me when I was developing my own skills was information about each instrument, like understanding each instrument and how it relates to the musculoskeletal demands. So I've put that together in a talk, in a workshop, which will go through instrument by instrument, instrumental group and then instrument by instrument, what are the specific demands of the instrument, what injuries we typically see, what are common treatment approaches and prevention approaches that can help.
Oh, that's amazing, Aviva. Really, I can't thank you enough for that, because that's exactly where I stumble. Half the time I have to look up the instrument because I'm not a musician. So it's really...
And that's great advice. That's great advice, to just look it up. And
yeah.
that's how I learned. Yeah.
Well, we look forward to seeing you at the summit, and thank you so much for your time so we could learn about your career. It's very, very exciting. And yeah, thank you very much. We'll see you soon.
Thank you, Robyn.